This is Walter Kemp dictating. This is Ischemic heart disease, part 3. This first slide, this is looking down on that actually in the center, that's Phipps Park. I live in the houses kind of to the left of it in the picture, right around there. So this is Billings. So there are the websites that Roteman and I have for questions. My Twitter, which maybe this weekend, probably start posting in, hopefully. And like I said, I'm a forensic pathologist is my specialty, but I have a strong interest in just general and organ pathology, and I really enjoy teaching medical students. Please pause, read the disclaimers, and then if they apply to you, please don't watch the video. I just want to teach people pathology, but I want to make sure people who watch this are ones who should be watching. Same thing for this. Third disclaimer, pause, read it, make sure that it fits. If not, then just quit watching the video. And then the last one, like I said, is if you're interested in my teaching methods and my thoughts, it's there and that. So these are the references I'm using. We'll start out with a question. So pause, look at it, see if you can figure out the answer. And we'll discuss at the end. And this is a good way to, they show that this increases retention during the lecture. Okay, so we're going to talk about the morphology of myocardial infarct. So of course, the morphology of it is going to include necrosis and then grossly infarct. And the mechanism is basically going to be you're going to have hypoxia, ischemia. And so one of the first things you're going to see is, and this will be early on, not really something usually seems like by light microscope, but the idea when you have hypoxia of decreased oxygen, and with decreased oxygen, you impair the sodium-potassium pump. And that impaired sodium-potassium pump is going to allow sodium to go into the cell, and then water follows sodium, so the cells will swell. And so that kind of irreversible and early on injury will be that cellular swelling. And then that's what, then you also get, it says increased calcium. The calcium will activate proteases, lipases, and that leads to cell death. And then you have increased anaerobic metabolism, which will lead to intracellular protons. The increased acidity of the cell causes clumping of the protein, and then that will eventually denaturate and lead to cell death. So these are kind of the general mechanisms that lead to the morphologic changes that you see very early on. So there are basically two types of acute myocardial infarcts. The STEMI or ST elevation myocardial infarct and the non-STEMI or non-ST elevation myocardial infarct. Usually the STEMIs are transmural and the non-STEMIs are subendocardial. My understanding of the definition of transmural is basically greater than 50%. So it doesn't have to involve the full thickness of the wall, but just greater than 50%. And then another thing we talked about earlier on, remember the subendocardial region actually is some of the highest pressure and actually is the highest at risk for hypoxic ischemic injury. And so is the first place you see damage. So I have this one and the next one, just the same thing. So the top left is roughly a subendocardial infarct. So there in the inferior wall of the left ventricle, you can see that yellow discoloration, which is kind of like the inner half. To the right of it, sorry, the coloration is kind of off and everything like that. I apologize. But I think you can still see basically the anterior septal region is discolored and it's actually transmural. That one I always wish I had a better picture of. I don't. But here are two other ones that are a little more recent. Top left is subendocardial. You can see at the white arrow just a little tan discoloration. That's in the subendocardial region in the anterior wall of that left ventricle. And then in the anterior lateral wall of the one to the bottom right, you can see that tan white discoloration that involves greater than 50% of the thickness. So that would be technically a transmural infarct. The thing about it is that, pathologically, I wouldn't want to say whether or not you'd have ST elevation or not unless it was like fully transmural or just barely subendocardial. Because, the ST elevation is a clinical change, which oftentimes correlates what we see pathologically, but not always. So one important thing is to discuss is the location of the infarct and the artery involved. So in most, if it involves the anterior free wall and the anterior portion of the interventricular septum, it's the left anterior descending coronary artery. If it involves the posterior or inferior free wall, you'll see those used interchangeably. Technically, it's the inferior wall is my understanding, but sometimes people use posterior. So you'll see that. And I think posterior is what's used most commonly, but technically it's the inferior. So the posterior or inferior free wall in the interventricular septum, inferior posterior portion of it. That's usually the right coronary artery, although in 10% of the people that can be the circumflex. And then the lateral free wall is a circumflex coronary artery. And so remember, the right coronary artery, which is going to supply the inferior or the posterior wall, that's going to be the posterior descending, and in 90% of people it comes from the right, but in 10% it comes from the circumflex. And then the top image between the black arrow and the white arrow, that'd be roughly the distribution of the LAD. Between the the line between the white line and the yellow line would be roughly the distribution of the right coronary artery in most people, and in the between the black and the yellow would be roughly the distribution of the circumflex. And you can see in that individual, there's an infarcted area in that. And then the individual at the bottom, the anterior lateral is infarcted. And then you can also see at the inferior septal, there's just a little white dot right there. That would be an area of infarct. So the factors that affect the myocardial size, of course, the place you involve the vessel. So if you involve the proximal portion of the LAD, that's going to infarct a much larger area of the myocardium than the distal part of the LAD. The size and duration of the occlusion or partial occlusion, obviously if you obstruct 100%, that's going to be a lot different than if you go from 50 to 80%. The oxygen demand of the infected myocardium, that's why subendocardium is affected first. It has a much higher demand and is more prone to injury. And then if there's sufficient collateral vessels, if the atherosclerosis develops relatively slowly, it's possible for it to develop collateral circulation. And if there's good collateral circulation in place, you could actually potentially occlude the vessel and not actually infarct the wall. So, point to ponder: in what specific group of patients and at what location could a single thrombus produce an infarct involving the entire left ventricle? I'll pause and then we'll give the answer. So technically, if you had a left dominant person, meaning the circumflex coronary artery gives rise to the posterior descending, and you thrombosed the left main, which would be what branched into the circumflex, and the left anterior descending, technically in that group of individuals, you could potentially infarct the entire left ventricle, or most of the left ventricle, because the inferior septal region would be supplied by the circumflex, which is coming off the left main, and the circumflex also be supplying the inferior lateral, and the anterior would be supplied by the LAD. And so since they're all coming off the left main, if you infarct the left main, you'd infarct essentially the whole left ventricle. Okay. So this is actually in Texas, not in Montana. I just thought it was a neat little, I think this was a sunset. So myocardial infarction, microscopic morphology. So basically some of the things that you see very early on, you can see what are called wavy fibers, and that's it. They just look wavy. And then edema, as we talked about in the initial slides, that early part where you get the loss of sodium potassium pump, you get water in the cell, you get swelling of the cell. Then you'll get coagulative necrosis. Then you start getting inflammation, where you get neutrophils first and then macrophages. Then you'll start repairing it. So first you get granulation tissue, new blood vessel formation, fibrosis, and some inflammation, and then ultimately scarring. And the morphology doesn't matter what the source for the hypoxia ischemia is, they'll essentially be the same. Although I have heard that if you have epicardial-based injury, that can be emboli, but I haven't seen for sure confirmation of that. But I know sometimes at autopsy we'll see individuals with more of an epicardial scarring, which is different than what is normally seen with, it seems like, with hypoxic ischemic injury in people with coronary disease. So the timing, there are just some rough guides. I know that it is used on the first aid, some of the stuff. But the thing about it is I always tell students, don't memorize the exact times, but know the rough time. Because if they're going to give you a question on it, they're not going to say, did this occur in 12 or 14 hours? Because that would be a very unfair question. So they're going to give you a broad range. So that wavy myocytes is one of the earliest ones. You can see that like 1 to 3 hours. You're going to start seeing contraction band necrosis around 12 to 24 hours. You can see the neutrophilic infiltrate can begin as early as 4 to 12 hours. Usually around 1 day you see it pretty well, and then definitely prominent by 2 to 4 days. Coagulum necrosis would correspond with early on, 12 to 24 hours. Macrophages begin about 2 to 4 days, which makes sense. Usually neutrophils come in about up to about 1 to 2 days. Then macrophages come in around 2, 3, 4 days, and they're going to clean up, and then you start getting granulation tissue around 7 days. So it basically follows what's in basic Robbins, the beginning of it, everything like that. So like I said, if you know the rough time, that should be good enough, I would hope, for exams. So the top left, these are wavy fibers, and I know this individual for sure had an infarct, because I've been told in that wavy fibers are fairly subjective interpretation. But you can see, I thought that was a pretty good example of it. You can see wavy, and probably the spacing in between it is some of the swelling and the edema. Bottom right, you see coagulative necrosis there. Right in the center, you can see a darker red area. The nuclei are either it looks like smaller or absent. And then you compare it to their surrounding one. So that's basically coagulative necrosis. So around 12, 24 hours. Then you're going to start getting the neutrophilic infiltrate. Like I said, I think you can see it maybe as early as a couple hours, usually by half a day. For sure, by a day, you're going to see some, and then it's going to be very prominent through the next couple. So the top left, this will be ones like 2 to 4 days. So macrophages are going to come in usually around 2, 3, 4 days. Obviously there could be some macrophages in there. You probably have to stain with immunohistochemistry to identify that, but it's not necessarily vital. Then the bottom right, these are macrophages. So you can see that to the right of it, you can see cardiac myocytes that are all preserved. Those are completely histologically viable. But to the left of it, the myocytes have all died. So everything has come in and cleaned them up, and all that's left are the macrophages. So this will be around 5 to 7 days. Then you start getting that granulation tissue. At the bottom, you can see the granulation tissue. You can see new blood vessel formation. You see collagen. You see some inflammatory cells. At the top of it, you see much of a dense scar. So dense scar is usually considered about 2 months. And beyond that, it doesn't age anymore. The bottom right just shows a dense fibrous scar. So here we have fibrosis. So it is evidence of old past ischemic injury, and then to the right of it, you can see coagulative necrosis. If you compare the cardiac myocytes on the right half to those on the left half, you can see on the right half are much more eosinophilic. You don't see nuclei. You see some contraction bands, and then that's coagulative necrosis. So what this is showing is this individual has ongoing ischemic injury with the coagulative necrosis, but had it in the past, and that's what is the fibrosis, which makes sense. I mean, if you have an area that infarcted and the person survives, it's also going to probably be an area that could be involved with a second ischemic type injury. And then what will happen is, as you get the scarring, you get compensatory hypertrophy of the surrounding cardiac myocytes, and so the cardiac myocytes will enlarge, and you can see those enlarged boxcar nuclei, and actually the heart itself can enlarge to some degree too. So timing of the infarct, Robbins has a really good one on this, but sometimes it seems like it's more subjective, if you ask me. That's why I like to do the microscopic first, because telling macrophages from neutrophils and telling the granulation tissue and stuff like that is much easier sometimes than identifying, well, is this shrunken or not? Is this slightly gray or not? Or things like that. So these are just some that Robbins says. The important one, though, is you're not going to see anything grossly for like upwards of a day. You won't see anything grossly, okay? And then you'll start getting a pale discoloration, then the increasing yellow, which you expect when you have all of neutrophils, that's like pus, and so get a yellow discoloration. And then as you start contracting it, as you start removing it, the macrophages start removing all the dead tissue, it's going to contract, and that's going to cause shrinkage, and then you can see the scar development, and that's going to progress until around 2 months. So to the left, this was an infarct with extensive neutrophilic infiltrate, so like around 2, 3, 4 days, and then you can see the yellow coloration that would associate with that with the neutrophils. To the right of it, in the anterior septum, you can see kind of more white discoloration, and in the septum, you can kind of see this grayish discoloration. That turned out to be just kind of granulation tissue in that. And then here you can see in the anterior in the anterior lateral and in the inferior lateral regions, mostly anterior lateral, you see this white fibrous scar. Okay, so here's the question. So if you want to pause, and we'll answer it. So pathology residents examining microscopic sections from an individual who died from myocardial infarct. If the image is representative, how long prior to death did the infarct occur? So the answer would be 6 days. So you can see those are all macrophages and everything like that. So it wouldn't be 3 hours. Microscopically, if you're going to see anything at 3 hours, you might see wavy fibers. 1 day you should see definitely coagular necrosis and neutrophilic infiltrate, most likely. 2 weeks you'd see granulation tissue, but it'd still be fairly cellular. 2 months you'd see dense fibrous scar. 6 days would you see macrophages and that. So like I said, I think it's good to know the rough ideas, and I think if they ask you on a test, and I've heard this is a fairly popular test question on the USMLE, they should give you a broad range of your choices and not nitpick it together, because I think that would be unfair. Okay, so this is once again reflection. So think back on the lecture. What are 5 things you learned from this? I hope you learned 5 things from this. And then, like I said, this is a really good way to help you remember the information and that's why I don't do a summary, because it would kind of defeat the purpose. And on these, if you have any comments or anything like that, please feel free to send them to me through the YouTube thing. I'd appreciate them. Anything for improvement or anything like that. And then that's it. There's Dallas. The last time I flew down to Texas, we got stranded in Dallas before we could get to Dallas. Dallas couldn't land or take off flights for 4 hours. But it's always amazing to me. I mean, how quickly they get the airports up and going in and get the flights going, everything like that, for such a complex system. I think they deserve some credit. So anyway, that's it. Thank you.